Okay, there you go.
Okay, I'm Dr. Vorster. I'm going to present on Sialocutaneous fistulas. I've got consent from the patient I'm going to present today. So the patient is a 50-year-old female, known with RVD, but well controlled with suppressed viral load for many years, also known hypertensive. And we know other concerning background. So presentation to us, she was referred with a draining fistula behind her left ear since 2020. With a history of copious clear fluid secreted while eating. And then preceding this, she had a history of a spontaneous abscess that ruptured in 2020. And since then, she had this fistula opening. And after that, she hasn't had any other infective episodes or facial swelling reported. Just the salariae from the fistula. So after seeing in the clinic, we contrast non-CT scan for her, and it was reported as normal with no lesions seen. There's also no evidence of lymphoepithelial cysts. Plan was then made to do initial conservative management for her, and she was given a trial of Botox injection of 25 international units, checked along landmarks in the left parotid. She only had a partial response with continuous salariae, but just decreased in amount over the following 3 months. And then seen again, after that, she had a second trial of Botox, this time 50 international units, and only again showed a partial response to that. So the patient had a presumed fistula post-sale adenitis, and the decision was made to offer the patient a superficial partial parotidectomy, which was done uneventfully. So just looking at parotid fistulas, there's two types of fistulas. There's ductal fistulas, origin from the duct, and then glandular fistulas. So with ductal fistulas, they usually have a fistula opening intraorally or on the cheek, and then with glandular fistulas, they usually have a posterior auricular or cervical opening. They can also have openings on the cheek, and then they can also have an opening in the external ear canal through the canal of Hush, but that's quite rare. And then they present with gustatory otorrhea. So differential diagnosis for sialocutaneous fistulas is most of them are traumatic, post tangential penetrating trauma. And next group would be infective, which are the obstructive infective post sialophysis or due to viral cellulitis. And then less common is fistula secondary to malignancies and congenital fistulas.
So we can start with you.
Let's see.
Okay,
so the traumatic fistulas, most common with tangential injuries, as I mentioned, and they report an incidence of up to 57% if the parotid duct is left unrepaired after injury. And then the second group is post-surgery. I think the most common is after temporomandibular joint surgeries as a complication, and then can happen after parotid surgeries as well. So about 4 to 14% incidence reported in the literature. And then it's more pronounced, the higher risk is tumors located quite anteriorly and close to the duct. And then also reported post-facial abscess drainage. So classification for ductal injuries is a Van Sickles classification, A being pre-mesenteric, that's usually the intraglandular duct, B being the duct over masseter, and then C post just after masseter muscle. Infective and inflammatory. So like I mentioned, obstructive, and that can be due to sialocutaneous, stenosis and kinks in the ducts, and then non-obstructive systemic disease, very important HIV cell adenosis as well. And when you get the idiopathic spontaneous, they are quite rare. Congenital fistulas are quite rare, with cheek or intraoral fistulas being most likely due to accessory parotid tissue with an accessory ductal system. And then external auditory canal through a patent canal of Hush, as mentioned. Differences between ductal and glandular fistulas clinically is ductal usually has copious discharge that persists, and glandular fistulas usually have initial copious discharge and then they rapidly decrease the quantity over time. Ductal usually don't heal spontaneously, whereas glandular usually, in the absence of infection, will heal. Ductal fistulas have poor response to non-operative management, especially the masseteric section. Glandular usually respond well to non-operative therapy. Ductal is usually secondary to trauma. Glandular is usually secondary to suppuration after a calculus. And then conservative therapy is usually successful in the ductal type if it's in the pre-masseteric duct. So workup include ultrasound to look for calculi and look for dilated ductal system, contrast non-CT scan to screen for malignancy, also a CT planning, surgical planning, then MR cellography, especially T2 weighted imaging, gives good spatial resolution, especially in obstructive disease. Then there's conventional cellography, CT cellography, cell endoscopy if obstructive lesions are suspected. Technetium scintigraphy can be used to assess the secretory function of a gland. And then if a diagnosis of salivary fistula is unclear, salivary amylase can be sent on the fluid. So conservative management include just observation. It often fails and patients have to live a prolonged period salaria. Then other things described as compression dressings and anticholinergic drugs. And this is more for patients with glandular fistulas. Non-surgical options include Botox injection and sclerotherapy, then with hypertonic saline, trichloroacetic acid and surfactants. So Botox seems to be currently the most used. The peak effect is at 2 weeks after injection. It lasts anywhere from 3 to 10 months, depending on multiple factors. The doses reported in literature is anything from 22 international units per 100 international units. And they report that some patients need repeated courses up to 9 injections before gland atrophy is achieved. And they quite reported to be 90% effective for fistulas post-parotidectomy in the literature. So mechanism of action for Botox, it binds to the presynaptic plate, inhibiting it irreversibly binds, it inhibits the fusion of acetylcholine cistal vesicles to the synaptic plate, and then it wears off as the nerve starts regenerating new motor end plates. Injection sites, literature report that multiple injection sites is better than just one single injection site. Usually 2 to 4 injection sites is suggested. Injection technique, you can use landmarks or you can use ultrasound guidance. So with landmarks versus ultrasound guidance for submandibular gland injection, they did a cadaver study and just by using landmarks, only 50% of injections actually ended up in this submandibular gland, versus with ultrasound guidance, 92%. And then for the parotid, using landmarks, 79% ended up in the gland versus 96% using ultrasound. The adverse effects of missing the gland with a parotid injection is not as severe as submandibular, because of submandibular there's extravasation to the laryngeal muscles. They can have dysphagia for the time until the injection wears off. This is just an image of what the two glands would look like on ultrasound imaging. So once the image is obtained, a needle can be passed into the gland in the with a planar technique and injected under direct vision. If one uses landmarks for the parotid, they usually then advise 2 injection points. The first being between the angle of the mandible and the mastoid tip, and the tissue is grasped in between the fingers. Injection is at about 1 centimeter deep. And then the second point is 1.5 centimeters in front and below the tragus, and also 1 centimeter deep. Sclerotherapy, there isn't a lot of literature surrounding sclerotherapy, but it's mostly in case reports, usually used for chronic fistulas. Good results has been reported from the case reports with minimal side effects, and it can potentially avoid surgery for patients. So further management of fistulas in the setting of trauma can be acute versus chronic management. There's no consensus as to which is better. So some authors suggest repair within the first 24 hours after ductal injury, and to prevent a fistula. Other authors believe that the incidence is low enough that they can be waited and the fistula be managed if it does occur. So management of traumatic fistulas based on the classification, it's a type A. Usually the duct can't be repaired and the duct is just tied off. It can be used in conjunction with Botox to avoid glandular atrophy. Type B and C, they suggest primary repair, which can be primary anastomosis, reimplantation of a duct, or an interposition vein graft or mucosal flaps. Another procedure reported in literature, especially for glandular fistulas, is endoscopic tympanic neurectomy, where there's division of the Jacobson's nerve in the middle ear cleft that provides the parasympathetic supply to the gland to decrease salivary secretion. Management of, so they can be used for both ductal and glandular fistulas, but more commonly for glandular. Failure is usually associated with anastomosis of the fibers with the border tympany, and in small case series were reported good results of this procedure. Other surgical options, especially for chronic fistulas, include fistulectomy, where the fistula tract is just excised and closed off primarily. Reconstructive surgery, especially in the acute phase, as mentioned before, but can also happen in the chronic phase. And then another management option is a controlled internal fistula. And then parotidectomy if other techniques fail to manage the fistula. And then also if there's any other indication for parotidectomy like a tumor. And then as an absolute last resort, radiotherapy, but it's more historically used rather than currently. It's got quite a few side effects. And then if there's any obstruction, you can try and relieve obstruction prior to using adjuncts, or you can do a primary parotidectomy for them. So when we reviewed this patient CT scan preoperatively, We actually did see a distal calculus in the parotid, which we didn't appreciate before. It was not included in the initial report. We didn't see any other calculi. This is a picture of a CT scan. First image you can see in the left parotid, the lesion, also demonstrated in the other coronal and coronal and axial planes. We really interviewed the patient, then reported that she actually passed a stone in 2015 after self-expression.
Thank you very much. So what did you do with this patient?
She had a superficial parotidectomy.
Parotidectomy with the calculus. Okay, and was the calculus underlying the fistula box?
Yes.
And you send it to that area. Okay.
But intraoperatively, we didn't palpate the calculus in the specimen, but also not in the parotid tissue that was left behind.
Okay, we can be difficult for this. There might be some fibrosis around. You do that. No,
No, I didn't question.
I saw before that. You know, I think I gave a photo on this one.
Yeah.
It's very interesting. It's very close area. So this is a bit of a diagnostic area. It's almost like a mastoid tip.
Yes.
So, what have you ever seen tumors present with this? No, I've never seen that. The only see give us overnight skin breakdown, root invasion. I've never seen it. I mean, I've done very few. I'm always amazed you don't see them much more often after people on the surgery. Well, they quote in your numbers 14%, but that's definitely not our expert. No, I mean, I've hardly ever seen it. I occasionally see the side of seal, and those are second down. So I've never had to do Botox in my life. So I haven't had to do that. Is Kashima on the call? Can you comment on orthopedic neurectomy?
I am on the call, Prof. Sorry, it's not coming through very clearly, the sound, but did you ask about tympanic neurectomy?
Yes. Do you think it works and is it easy to do?
It's not difficult to do, and as he was presenting, I thought, I'm not sure why we do more of these, but we've never actually done it. I mean, it's not difficult to do. It's very easily accessible. I'm not sure why we've not tried it before. It's just, yeah, I think we keep forgetting that there is a tympanic neurectomy that can be done as another option. I don't have any experience with tympanic neurectomies, but I mean, it's not difficult to access or even difficult to do.
Yeah. I mean, I always dismissed it because I read somewhere that it doesn't work, but it might be the case. I mean, is it good evidence that it works? You said it's small case study.
Okay, small case series, so it's difficult to. There's no big review on them.
Yeah. Well, at one stage it was quite in fashion 10+ years ago that didn't have great results. Yeah. And then I don't know, that's endoscopic, so that's obviously a new paper. I think also I think you might look carefully at the patient selection for that series, because most of these just get better by themselves. I think if you're going to be using stereotherapy and other treatment for trying it, just remember you might have to go and do parotidectomy subsequently. You don't want to make your subsequent surgery difficult about it. But as I say, I've hardly ever seen. I've got one lady who's got a fistula over the gland, which I think might be TB. So that's not a side of it, that's a slightly very, but then you can also get those as well. Any other comments, Matt? Any comments from you? And there's another presentation. I haven't had to repair the product back. Maybe plastics that is more with the trauma cases. But often easy to just take the gland out. The big background funds. Thank you very much. It's very the question in the chat.
Is there a risk of facial palsy or Botox injection? No, because it works on the motor end plates. It doesn't work on the nerve axon or the so there's no risk on.
No risk, yeah. I think that's what it is.
The risk is there can be, so when you inject Botox, there's about a 1 cubic centimeter spread, diffusion from your injection point. So if you inject too deep, it can actually go into some of the musculature below paralyzed bones.
Okay.
So
it doesn't affect the actual nerve getting at the end plate. So that's really right at the muscle.
yes,
We can
right.
that's muscle. Okay. Any other questions? Okay, thank you very much. Yeah, very nice of you.
Thank you, everybody.